Because that's what we're doing. The way I broke.
All right, so what do you have questions about? I don't have a plan. Let's go to,
Upper motor neuron, lower motor neuron. What you mean by that?
upper motor neuron is within the CNS. So it's the piece that's, what is it? That's from the brain all the way down to where it leaves the spinal cord.
Got it.
That's an upper motor neuron. It's usually it's a motor neuron. So it's going to a skeletal muscle of some sort, right? It could be going to be a cranial nerve, but it's going to a skeletal muscle. So if you have like an MS or CNS disturbance of some sort that's interrupting that motor neuron, that's an upper motor neuron disease.
Gotcha.
Right? And then lower motor neurons is from just outside the spinal cord all the way to the muscle itself. And that lower motor neuron is what provides little trophic factors to grow your muscle. So if you have lower motor neuron disease, you're going to get atrophy a lot quicker. Also, your lower motor neurons are, they can be involved in reflexes, but the upper motor neurons is what's preventing some reflexes. That's why with like Babinski, which is the up pointing toes, your body wants to do that, but you have what I call flexor responses in your brain that prevent that from happening. You should normally be flexing, but they have with Babinski, when you have upper motor neuron disease, they have up pointing toes. Like MS has the up pointing toes. What other disease has up pointing toes? ALS, right?
So it would be safe to say that one is like this is central nervous and the other one is
Pretty much.
Okay, gotcha.
All right. What other questions do you have?
So staying on the topic of neuro, for the PCA with the occipital lobe damage, for the neglect, the total vision loss in one eye versus the hippopotamus, how is it either or? Is it both?
For PCA?
Yeah.
So does it have homonymous hemianopsia or hippopotamus,
Yeah, hippopotamus.
So yes, it has that because it's affecting the occipital lobe at that point, right? Because it synapses your optic nerve crosses right behind your nose, and then it takes a little rest stop, little overnight stop right there in the temporal lobe, right? That's why MCA strokes can also have that finding, and then it ends up in the occipital lobe. So you can have half your vision loss, all right? But the important things, if you do have that, what are the considerations? What do you have to do for the patient?
Approach them from
The good side, right? Approach from the good side. Don't approach from the bad side, but they're tray on the good side. They're a fall risk, or they can bump into things on the other side, right? So homonymous hemianopsia is going to be that's one of the things that happens. And the other question was what again?
Do they also have the contralateral vision loss, the total vision loss in just one eye, or is it either or?
It's half of both.
Oh, it's half, okay.
Mhm.
So there's no difference between contralateral vision loss and homonymous hemianopsia.
There is, but we're not getting to that. No.
Gotcha. Okay.
The important thing is know that if they have an MCA stroke or a PCA stroke, they have vision problems, right? So that we have to be aware that they're a fall risk, that we have to make sure we do avoid neglect. And how else do you teach them? It went away. How else do you teach them? What else would you teach them? Yeah, visual scanning. What does that look like?
Moving your head side to side.
Yeah, trying to think that's what is it? The hocus pocus. You know how they walk, right? Like this, right? So it's a hocus pocus walk. Right, you put a hocus pocus on the TV. Okay. So we put it to the chat. That's what a hocus pocus walk looks like. Okay, for those that weren't born in the 90s. What else? So yeah, so for strokes, you have to know what kind of interventions and nursing diagnoses you would associate with these different things, right? So if they have, which one has swallowing problems? Yeah, it's your basal, right? It's your basilar artery, right? That's the one that's going to be affecting the cranial nerves. Your cranial nerves are your oculobulbar. I brought that up because that's applicable to almost each one of the neuroprocesses we talked about, right? It happens in a different fashion, but it's still oculobulbar symptoms, right? Either the muscle itself is not getting the acetylcholine activity, right? Because the receptor was destroyed. Which disease process is that? Acetylcholine receptor is destroyed. Not ALS, no, not MS, not Alzheimer's, not Parkinson's, not Guillain-Barre, but myasthenia gravis, right? So myasthenia gravis has ocular bulbar reflexes or weakness because you are losing the ability of the muscle to contract at all, and they get ptosis, right? Or and they also have fatigability, which is classic because they have acetylcholine in the morning, but as they have less receptors throughout the day or less ability to recycle. I don't know the best way to describe that, but they get fatigability. That's a classic sign, right? They have difficulty chewing, difficulty uterusing, difficulty looking, right? So they have problems. That's how you can assess that they need their medications. Which is what medication?
Myasthenia gravis.
Mm-hmm. Yeah, so neo or pyridostigmine, right? So those guys are going to allow the acetylcholine to stay there longer so that they can maintain contractility for longer, right? And how do you give those meds? Mm-hmm. Yeah, but how do you give them? When do you give them? I guess better way. Around the clock, right? And before meals if they are not NPO, right? If they're taking food by mouth, then they should take their pill by mouth 30 minutes before their meal, so they can actually chew their food, right? Yes. Why do you cluster the care? So because if you do it all throughout the whole thing, or that's going to be fatiguing them out. So you want to do it at one time, right? I know you MS, you cluster the care. Did I say that you do it for myasthenia also?
No.
Don't cluster care. Yeah, as I was saying that, it sounded like I was saying a lie. All right. So, anyways, yeah, you don't cluster care with myasthenia. You're gonna space that out. MS, you would.
So I guess the reason is then why? So you don't burn up all the.
Yeah, you don't burn out because they get fatigued. So you want to let them build up their acetylcholine again, and they can then be ready again for the future.
Perfect. Thank you.
Yeah. So for myasthenia gravis, you're going to do not cluster care. You're going to space out your care. Whereas multiple sclerosis, you're going to do it all at once. Okay, so yeah, the ocular bulbar piece, so you can have the neuromuscular junction be destroyed, or you could have the wrapping that goes from the brain down the lower motor neuron to those ocular bulbar symptoms, right? And which one's that attacks the wrapping, the electrical tape around their nerves? Which one? MS, no. GBS, Guillain-Barre, is attacking the Schwann cells in the periphery, right? Going from the spinal cord to the actual muscle itself. That's Guillain-Barre. Let me draw pictures for you. Hold on. Let's do new share. All right, so this is what I'm talking about. It's got ocular bulbar, right? So you got the spinal cord here, you got the CNS, right? You got one hump, two humps, right? You got the medulla here, and you got the pons right there, right? And then we have our muscle out here, right? Doing our things. And it can be any muscle. It could be the masseter muscle, right? Or it could be a muscle that's innervated by our cranial nerves, such as, 3, 4, 5 could be our 3, 4, 6 could be our eye muscles, right? So if their eye muscles don't work good, they're not in concert, not synced, they're going to get double vision, you get diplopia, right? If it's going down to our eyebrow, facial nerve, right? That's going to be hitting the eyebrow, the eyelids, right? That's going to cause ptosis, right? So you can put all those on there, right? So got ptosis can happen. You can have diplopia if we're doing the diplopia, if we're doing the ocular bulbar stuff, right? So those are all of those different things because those muscles don't work good, right? So if we have Guillain-Barre, right? That's a neuron that's going from the periphery, right? So we have little synapse to say, hey, I want to move my eyes. All right, that comes from the motor cortex. It goes down. And that's an upper motor neuron up there, right? Upper motor neuron. We got our lower motor neuron down here, right? And then with Guillain-Barre, what color is Guillain-Barre to you? Green. All right, so Guillain-Barre is attacking these guys, the little Schwann cells, right? So GBS is attacking these guys.
How are those different from myelin sheaths?
Those are myelin sheaths. Guillain-Barre attacks the myelin sheaths in the periphery, and those are called Schwann cells, right? Whereas our myasthenia gravis is attacking, what's another color? I don't have any options here. Let's do pink. So you got myasthenia or right here. We're destroying so here's our neuromuscular junction right here, right? We have little receptors there. We're releasing acetylcholine, right? Release little acetylcholine there, but these receptors are destroyed, right? And that's because of what process? Which disease process? Yeah, myasthenia gravis, right? It's destroying the neuromuscular junction. Whereas if I didn't leave enough room here, we'll do another neuron. All right, so we got coming from the upper motor neurons, we're synapsing there in the medulla, let's say, and we're going out to the nerves as well, doing a different muscle, right? So what if we have destruction of this actual nerve itself, the inside of the nerve is getting destroyed? That's ALS. If the outside of the nerve is getting destroyed, let's do red, right? These little oligodendrocytes are getting destroyed, right? That is MS, right? It's destroying the outer covering, like Guillain-Barre.
So it just depends on where in the central nervous system the myelin is located.
Yeah. That's destroying myelin. GBS is destroying myelin.
Just in the lower motor neuron versus the motor.
Or is it in a different order or is it different locations?
Well, the sclerosis has no pattern to it. It just attacks anywhere throughout the CNS.
Okay, so we would have to look for,
Throughout the CNS only.
okay,
Whereas ALS is attacking the nerve itself, the skeletal muscle nerve. The nerve that's going to that skeletal muscle, it's attacking the inside, the glutamate receptors, all that other fun stuff. Right. So how do you apply that? So they're going to have, you can have you can have ocular bulbar symptoms. So MS really encapsulates all the symptoms we've been talking about because it can attack the basal ganglia and cause what disease? Parkinson's, right? It can attack the hippocampus and cause what? Alzheimer's, right? So they can attack the frontal lobe and cause what symptoms? Judgment, right? It can attack the limbic system and cause what symptoms? The limbic system. It can attack the limbic system and cause what symptoms? Yeah, a little bit of agitation, but it's going to be more sexual dysfunction, right? So they can have mood changes as well. But also if it's going down to the nerves that are going to the sexual organs, that's going to cause dysfunction as well, right? So usually they have exacerbation of their symptoms, right? They have an MG crisis with an MS relapse, right? They have an MS relapse where their symptoms are worse, right? And what medication do you give if someone has a relapse? You give IVIG, you will try them with steroids first, right? And then if that doesn't work, you can do IVIG. And then what's the third option? Do plasmapheresis, right? Plasmapheresis to take out all the circulating antibodies produced by what cells? By the B cells, right? The T cells actually attack things, right? They go out and they just hunt around and they attack things that look sus, but also the B cells have released antibodies and they attach things, which lights it up like a flare, like in the side of the highway. And the T cell, oh, look at that, when we pull over, help this guy out. And I stab him, right? So have you heard of apoptosis, right? All right, so that's what B cells and T cells, your immune system does, right? It's ruthless. Okay, so it's kind of your neuro symptoms, right? So you have ocular bulbar symptoms. That's going to be each of these processes have that, but what's unique, right? So we said myasthenia gravis has fatigability, right? Guillain-Barre has what unique findings? It's ascending, right? It's ascending and it's also areflexic. Whereas some have Babinski, right? Who has Babinski? Our usually ALS and our, which other one?
And GBS, right?
GBS is areflexic, it has no reflexes. Yeah, MS and ALS have no Babinski, or sorry, they have an up-pointing toes. I hate Babinski because he described it wrong and he doesn't want to admit to it. Right, there's a Babinski Foundation, right? They update his books every year. No, I'm kidding. So yeah, so that's it's not Babinski reflex is inappropriate. It's not usually when you describe reflexes, you say, oh, that's a good reflex. That's a sucking reflex. That's a defensive reflex. But that's the reflex he described is abnormal, but he won't admit it. Okay, so you say up pointing toes is bad. That's not a good thing, and that up pointing toes is Babinski's sign. All right, so yeah, so areflexic and ascending. So as the two A's, right? That's a sign, that's Guillain-Barre. And then its treatment is not steroids. So the S and GBS is not for steroids, unfortunately. Okay, but you still do IVIG, you can still do plasmapheresis because the B cells are producing antibodies that are circulating in the serum that are going to find their way to a Schwann cell, right? Or the B cells are producing antibodies in the serum that are going to attacking the oligodendrocytes and MS, right? Or it's going to be attacking the neuromuscular junction. So if we draw B cells in here, let's put a highlighter here. Let's do red, right? So B cells are producing little antibodies, right? That are going to be attacking the cells in the myelin sheath in the CNS, right? Which is which one? Which is MS, right? So MS is an antibody related problem, right? Whereas GBS, you're producing antibodies against that, right? And that's a antibody problem, right? It's a B cell problem. So IVIG is going to work, right? Steroids prevent the infiltration of stuff into tissues. They hold everybody back and they say, everything's fine here. There's no reason to come in, right? We're perfectly fine. And then also we have antibodies attacking these guys, right?
That's why there's no real cure for ALS, because
ALS does not have antibodies. Yeah, well, yes. So ALS is just a problem with neurotransmission, right? You give what medication for that? Riluzole, right? So riluzole is a medication for ALS that you give. Glycopyrrolate, yeah, glycopyrrolate for symptoms, right? So what kind of symptoms? Drooling, right? If they wanted to stay awake, what can you give them? You give mycophenolate, right? If you want them to not have constipation, you give them what? Stimulants and osmotic, not diuretics, but diarrheics, right? To make them have poop. So you give Senna or what's the no Docasate's it's Docasate the same thing as putting in the trash can. It doesn't do anything, right? Docasate doesn't, but our Miralax, which is polyethylene glycol, and we have Senna, the sinusoides or something like that, right? So those guys are to help with the GI symptoms, right? If they have bladder retention or they have urinary retention, what can you give them? It's Lomax, maybe. That's usually for prostate. But you give the anticholinergic, right? And who shouldn't get anticholinergics? Old people, and who else? Alzheimer's is going to worsen their symptoms. Parkinson's, it's only for young people, right? But you can't give the same anticholinergic for the belly that you could give for the brain, right? Unfortunately, they have all different last names, right? You have atropine, glycopyrrolate, oxybutynin, topiramate, or something like that, right? And you have the tetrahydrophenadol. What's it called? I've even forgotten it. Tetra, is it not tetra, right? What is it? Tetrahydra something. Right. So yeah, those are all different anticholinergics that work in different areas, right? Whereas in Alzheimer's, we promote the activity of acetylcholine, right? Acetylcholine is attached with memory, right? So we give, guess what, acetylcholinesterase inhibitors like medications, just like which other disease process? Like the one that uses pyridostigmine and neostigmine? Yeah, like myasthenia gravis. So yeah, so DRG is your ones, like Dr. G, right? Those are the ones that are for Alzheimer's, right? So what are those ones? DRG. Donepezil. Rivastigmine. There's a stigmine, so that's nice. Memantine is not acetylcholinesterase, but it is medication for Alzheimer's. What's one? Galantamine. Okay. So yeah, so those are your ones for Alzheimer's, right? So they have side effects of what? Sludge BB. What are side effects of sludge BB? What does that mean? The salivation, urination, right? Defecation, GI distress, which doesn't follow the defecation. Emesis, emification, I don't know. Vomication. Bradycardia and bronchoconstriction, right? So those guys are side effects of all your medications that can promote acetylcholine activity. Whereas if you block acetylcholine activity, what are you going to have? You have dehydration, right? You dry, right? They have dry eyes, dry mouth, dry skin, dry vagina. They have all things dry. Okay. So which medications are some anticholinergics? Like we just mentioned the bladder spasm ones, but what about another section you have to study? Which one? New app. Okay. Yeah, in respiratory, good. So in respiratory, you have there we go. Respiratory, you have some medications that are anticholinergic, right? Which ones?
Is that your LABA?
Not your LABAs, but your LAMAs, right? You have your LAMAs and you have your SAMAs, right? SAMAs and LAMAs. So tiotropium and what's the short-acting one? Ipratropium, right? So those ones are for short-acting, right? And they have side effects of dryness, right? Dry eyes, dry everything. Okay. So that they're going to prevent or promote bronchoconstriction. Prevent. They're for asthma. So it's like, oh, I'm going to give you medication that's going to squeeze off your airways. All right, see you in the 3, right? So yeah, so that's your to me, you're connecting the cholinergic piece, right? So they have anticholinergic properties. So therefore, you can also have what effect on the heart rate? It's going to increase heart rate, right? So atropine is a anticholinergic for bradycardia, right? It's anticholinergic. It stops acetylcholine from doing its thing on the heart. And what's its thing on the heart? Sludge BB, right? It's B for bradycardia, right? All right, well, what else? All right, so for neuro, you want to know this, the immobility complications. And there's a lot of them. Almost each neuro process leads to immobility, right? So at the bottom here, I talked about the complications, immobility complications. When I went over this, we went backwards. So we started with ALS. So it has all the goodies in here. All right, so immobility and your complications of it, right? So you just think of head to toe. If you have to draw a stick figure when you're teaching it, just go head to toe and what the side effects are, right? Or front to back. And the back, you get D cubes, right? In the front, I guess you could think of lungs. I don't know. So what happens to the lungs? They get pneumonia. They get two flavors. What are they? Aspiration and atelectasis, right? So how do you prevent atelectasis? Yeah, do IS, right? So get an IS in is going to help if they can do it. That's gonna help, right? And then for aspiration pneumonia, how do you prevent that? Yeah, you elevate the head of bed. It's a good one. What else? You can thicken liquids. What else? Brush teeth. I don't know. They're gonna have some fresh breath, but they might aspirate. What else? They can do a swallow test ahead of time. So if you notice someone's having trouble swallowing, you can do the nursing bedside swallow. For strokes, it's very specific. You only get one chance. Whereas Parkinson's, you can try 12 times, 15 times, doesn't matter, right? But yeah, stroke is just and Medicare said that it has to be once, right? All the billing things has driven that. So yeah, so just one time, then you get speech therapy involved to help them out with that. And then PT can be help with immobility, right? As long as they don't have debilitating stroke or debilitating degenerative disease process. Okay, so you got pneumonia, you did lungs, you did skin. How do you help the skin out? Turn them every how often? Every 2 hours, right? And then what other complications? So you get a UTI. You know about UTIs from yesterday. What do you do for UTIs? Antibiotics, okay. Well, how are you going to prevent the UTI? For these neuro patients, it's hard. You can't like, okay, you're going to wipe front to back. Okay, I can't move my arm. Right, but yeah, so a normal person, you can teach them, front to back. And if they do have one good arm, they can do front to back also. What else? So fluids are good, right? So how much fluid? 8 to 10 glasses, right? And what else for UTIs? Do cranberry juice. What else? Vitamin C. You can encourage vitamin C, right? So what's a vitamin C containing food? Citrus is cinco, right? It's the 5th place. So guava's good, right? Strawberries are good. Bell pepper is great. I think it's a 2nd or 3rd place. Okay, we're going to Chipotle next, right? So yeah, so you have those are it is that's for doing what? What does vitamin C do? It acidifies, right? So vitamin C acidifies the urine because bacteria like to grow in what environments? In alkaline, so we make it acidic with vitamin C, right? So yeah, dark, warm areas promotes UTI. So how do you prevent that with, especially like a stroke patient or a neuro patient, neurodegenerative patient? Keep them dry. So you make sure they wear briefs or no briefs, diapers or no diapers. Yeah, no diapers, so just the chucks. The diapers are only supposed to be for ambulation, right? And you change them as needed. You're not going to wait like 6 hours, 4 hours. You're going to change them, right? Otherwise, in a hospital setting or in a setting where they're bedbound, you're going to just change the chucks underneath, right? What else UTI related? I feel like we're missing something. How else to prevent a UTI? No douching. It's not going to be the Alzheimer's disease primary concern, but no harsh soaps. Yeah. What else? Mhm. Yeah, avoid Foley catheters, right? Avoid indwelling catheters is preferred. Use an external catheter. Okay, so we got pneumonias. Well, VTE, what that's circling back to last test. What is VTE prophylaxis? You can ambulate them if you can. What else? Do stockings and SCDs, right? And then you need to do anticoagulants, right? Not antiplatelets, but anticoagulants, right? What's the difference? Okay, prevents coagulation. Okay, good. All right, so anticoagulation for anticoagulation, antiplatelets for antiplatelets, right? So yeah, so platelets, usually anticoagulants are given when there's a clot or when you want to prevent, you have like a high risk for a clot. Whereas antiplatelets are to prevent the platelets from getting activated at all, right? So they're not at all, but you know, like 70%. So if they see an atheroma rupture, right, they're not going to go over there and suck its collagen. Okay. What else? BTE, you're missing anything? Emotions, right? So you got to think about emotions. You have a whole semester for emotions or rotation about emotions, right? What else? So incontinence, UTIs, right? Bacteria. Love alkaline environments. They love what other kind of environments? Stasis, right? And that's kind of with like valve disease. You can get endocarditis, right? Because the more turbulent part of the heart, there's less movement is around the valves. That's kind of where they percolate and grow if they introduce bacteria. So how do you get bacteria introduced to your valves? Networking, yeah, okay. No, if you use what? IV drug abuse, right? What else? Dental procedures can be like really invasive. What else? Central lines is a big one, right? So central lines is, it's just IV drug abuse with extra steps, right? So it's going to we're going to put a catheter in you and we're going to give you drugs, right? IV. So yeah, so that's going to be also a way to get eclampsia, right? So how do you prevent that?
Dressing changes.
Dressing changes, and how would you say, oh shoot, that looks like eclampsia? You got purulent drainage on the site, right? The site looks grody, not Brody, but grody. Okay. So yeah, so that's, and also you can have symptoms of endocarditis. They have a fever, right? You might hear a cool murmur. What kind of murmur might you hear?
Diastolic.
Yeah, it can attach any valve. It does attach to the tricuspid more likely, but it could be any valve. Usually it's the AV valves, but just murmur wise, you have to know if it's systolic or diastolic, right? So which one is arms? Like you have arms parts. That's your diastolic murmurs or arms, ARMS, right? So AR, aortic regurg, and MS is multiple sclerosis. No, right? So yeah, so that's mitral stenosis. All right. So those are, so you differentiate the systolic or diastolic murmur, and then where do I hear best, right? So where do you hear mitral murmurs best? For the mitral area compared to the aortic area, which is where you hear aortic murmurs, right? All right, what else? We got incontinence, VTE prophylaxis, and then bone muscle loss, right? So it's a downward spiral. So elderly actually lose like about 20, like almost like 20% of their muscle mass per day when they're immobile. So it's a lot of muscle mass they can lose. So you want to use it or lose it. Okay. All right, what else? What other direction you want to go? So the respiratory. So it's highlighted. I think I don't know if I finished it or not. I think I did. All right. So respiratory, you have two disorders, right? You want to compare chronic bronchitis versus what other COPD? Emphysema. So you want to know the interventions for both. You want to know the medications are the same, but the kind of the symptoms for both and the interventions for both will be different, right? So it's a good STATA question to compare and contrast. This patient has chronic bronchitis. Therefore, I'm going to keep the SATs where? No. Going to keep the SATs high, right? More than 92, like 92, 94, right? Compared to, because they're chronically hypoxic, right? It's like, yeah, I know you're chronically hypoxic, but I'm going to keep you just a little bit, a little skosh hypoxic. I don't want to go too high, right? So how do you know they're chronic bronchitis or a emphysema patient? Yeah, so you can look at the labs that says blue bloater. Okay. Sir, you have chronic bronchitis.
I see.
Emphysema is chronic CO2 retainer. So how do you know someone's a chronic CO2 retainer? ABG is the best way to look at it, right? Also, you can look at the venous CO2, which is your bicarb, right? And the bicarb would be high, normal, or low with someone who's a CO2 retainer. It's be high because they have high CO2, the bicarb is going to compensate because that's an acid, right? So if you have like a scale, right, and you add a whole bunch of acids to it, we got to add some bicarb to bring it back up, right, to neutralize it. So they're going to have a chronic bronchitis patient is going to have a which is emphysema patient is going to have as a CO2 retainer, they're going to have a high CO2 and a high bicarb, right? That's going to tell you. The labs can tell you if you're crafty, you can look at the venous CO2 or you look at the ABG, right? So there will be ABGs for neuro, for respiratory, and for like metabolic things. What are metabolic things? Yeah, DKA, right? Things that will kill you, right? Such as what? DKA for K. I ingestions, we're not going to test you on ingestions. Lactic acid, right? And then U for kidney failure, right? The urea itself does not cause acidosis, but the kidney failure and evidence of kidney failure is when you have a BUN that's sky high. And usually the BUN sky high, that means your kidneys probably aren't working either. BUN is not the best way to assess kidneys. What is the best way to assess kidneys? Is the creatinine, right? So BUN and creatinine are elevated. They're both probably be elevated. The BUN is super, super high. The creatinine is probably high too, right? And therefore you can get what kind of acidosis, metabolic or respiratory? A metabolic acidosis, right? And those guys will have a bicarb that's what? Low or high? Low, right? They have a low bicarb. Bicarb is what drives, if that's low, and that's the one that's causing the acidosis. I'm not going to give you two, like a mixed acidosis. We have a CO2 that's high and a bicarb that's high, low to cause acidosis. All right, so ABG wise, are you good in ABGs? You want to keep thinking about ABGs? All right, so emphysema has a high CO2 and a what kind of bicarb? High bicarb, whereas a chronic bronchitis has a what bicarb? Normalish, right? What's going to differentiate a chronic bronchitis patient? They're probably going to have what? What's ABG disorder? Chronic bronchitis. Respiratory alkalosis, they're hypoxic. So your PO2 will be what? Low, right? What's low? Less than 80. So they're usually going to be sitting at like 50, 40 even maybe, all right? But usually they sit in the PO2 of 50, all right? That's a sign that you have chronic bronchitis. You have chronic hypoxia. All right, because remember 4, 5, 6, 7, 8, 9. So 4, 5, 6, PO2 of 60 is equivalent to 7, 8, and 90%, right? So if they're hypoxic all the time, might be sitting at 90%. They might be sitting at 50 in the 70s, or even 40 in the, sorry, yeah, so PO2 of 50s is a stat of just close to 70%, 80%, mid 80s. That's what they're walking around with.
Why would they do
Respiratory acidosis happens when you have CO2, right? CO2 is what tells you if you have acidosis. If CO2 is the problem, that's respiratory acidosis, right? So oxygen CO2 have no relationship to each other. They when O2 is high, that doesn't mean the CO2 is low, or vice versa. They're related. They see each other like going off shift. Say, hey, what are you doing? I'm going out, right? Oh, I'm going in and they can hook up the hemoglobin, right? They're going back and forth, like they're changing shifts, but they don't interact, right? Your body will react to low O2 or high CO2. And if their O2 is low, what's your body going to do? You're going to trigger the SNS and increase your respiratory rate, right? But a chronic, if you're like super hypoxic, you get to the point where your hypoxia is so severe that they say, I'm tired and I can't breathe anymore because the signal in the medulla is not getting the O2 and it can't send out the SNS signal anymore, or the muscles are getting fatigued, right? Or the diaphragm is getting fatigued, doesn't have enough oxygen circulating around to actually do its thing. And then now you're at risk for respiratory acidosis because now you don't have the O2 for your muscles to move. Right, so that's always the complication of respiratory alkalosis is you could lead to respiratory acidosis. They get fatigued. Right, so that's chronic bronchitis ABGs, emphysema ABGs. Right, emphysema ABGs have what kind of CO2? High CO2. Right. All right, so you still want to talk about respiratory stuff? Right, so asthma and COPD. So we talked about COPD and differentiating the symptoms of COPD. We talked about the ABGs difference, but the lab difference. They're both going to have problem getting the air out, right? So that's your which test is that? You can assess if they're, yeah, the FEV1 specifically per FVC, but FEV1 is less than 70%. That's a sign you got COPD, right? compared to less than 80% is asthma, right? So that doesn't differentiate chronic bronchitis and emphysema, but which one has right heart failure or cor pulmonale? Chronic bronchitis or emphysema? Chronic bronchitis is chronic hypoxia. Chronic hypoxia leads to certain complications, whereas CO2 retention all the time and air trapping leads to, which is emphysema, leads to other complications. So emphysema has less complications, which are what? You get barrel chest isn't really a complication, it's just a feature. What's the complication you get with air alveoli? They get bigger and bigger and bigger and bigger and bigger and they pop. You get pneumothoraces, right? You get pneumothorax, right? That's a complication of emphysema. Okay, and that's what symptom would that be? If your lung pops, sudden shortness of breath and chest pain. What else? Ipsilateral or the same side as the pop, right? You're going to have breath sounds or no breath sounds. No breath sounds, right? What if they have no breath sound, or they have breath sounds that are clear, but they have a they look hypoxic. Breath sounds are very, very clear. They sound, there's no wheezing. They're just fatigued all the time. They have clear breath sounds and fatigued and hypoxic. What does that look like? It's like anemia, right? Who gets anemia? CKD patients, right? Usually your COPD patients will try to compensate by that by triggering EPO to get released to make them polycythemic, right? And that's not emphysemas. That's what that is. Chronic bronchitis has low oxygen. So low oxygen leads to polycythemia. It leads to clubbing, and it leads to cor pulmonale or right heart failure. Okay. And what else? So what do you teach them? What is some teaching you can do for these guys? Who gets pursed lip breathing? Emphysema patients. They gave nothing for the chronic bronchitis. It's like, my nurse told me to do that. It's like, okay, all right. What else did your nurse tell you? So that's the chronic bronchitis is not going to help them. It will help your emphysema patient because they have air trapping. We don't want their airways to collapse after as soon as they start exhaling. So you teach the pursed lip breathing to your emphysema patients, right? And then what else do you teach? Where they're oxygen for 15 plus hours, right? And then who else? What else do you teach them? No smoking, stop smoking. Move to a place where you have less air pollution if you can. Oh yeah, I'll go to my third home, no problem. You're right. I should quit this home and lease it out.
Let's go move to the beach.
Yeah. Yeah, I don't know why I've been living up here the whole time. I should go to my Venice house. Yeah, so the air pollution could cause it. And then what about, should they euthanize their animal or their grandpa? No. Right? My grandpa smokes all the time. No, so yeah, you don't have to, you just have to not sleep with your pets or your grandpa, but not sleep with your animals, put them in a different room. Right? That got weird quick. Anyways, you get with your animals, right? Choose animals that have less allergens, or grandpas that have less allergens. I don't know. Right? Make sure you wash your sheets every week, right? You get a humidifier. That's for more like drying things out, or like a air purifier would be more prudent. Okay, those are interventions for your asthma patient, right? You don't teach pursed lip breathing to your asthma patient, right? So those are those interventions you do for your COPD patients, right? And for asthma patients, what are interventions you do? Avoid triggers, and what else? Do allergy testing, find out what their allergy is, know what their triggers are. It's important, so they avoid them. Peak flow meter teaching, right? What's the PFM teaching? Is it exhale or inhale fast? Yeah, PFM is exhaling fast. Peak flow meter is just a measure of forced vital capacity. All right, so they say here, blow as hard as you can, and we're gonna measure that and compare it to your age group and to your performance, and they do all kinds of fancy calculations to figure out where their yellow should be, where their green should be, and where their red should be, right? And that's what they have measured as what they're expected for their disease process, right? So that's the predicted value. So if they're at 50% of the predicted value, less than that, is that good? No, that's the red zone, right? So less than 50% on their PFM, they need to do what? They need to give a rescue inhaler, right? And then they need to see if they're coming up. If they're not getting into the yellow zone, then they're still in the red zone. they have to call 911, right? That's so it's important to teach about 911 how to do the PFM, but also how to where what's concerning, right? So they have to have their rescue inhaler with them. What's a rescue inhaler? What variety? It's a SABA, right? So they have a SABA available to them. They have rescue, they have reliever and controllers, right? So the reliever is what? That's a rescue inhalers. So they got rescue / reliever. They got controllers. And what's the other one? What is it? Preventers. There it is. They don't mean anything to me when I say preventer. It's like, well, I'm thinking that those two, I think of the kind of same thing. Preventer, controller is like, what's, anyways. So yeah, you have inhaled corticosteroids, right? And you have oral corticosteroids that could be on. Okay, and then what else do you have? What if you have oral corticosteroids? What symptoms could they have? What side effects could they have? They have Cushing's, right? And the Cushing's, what kind of attractive features do they get? Get moon face. They get a buffalo hump. Thin extremities, right? So this was a gift down here. It was supposed to be a flapping penguin with thin arms and thin feet. It is going to run funny. Okay. So yeah, so those are side effects of oral corticosteroids, right? And then what else do you teach an asthmatic? So you got PFM, what else? How to use inhaler. So inhaler teaching, right? So it could use a spacer if they want to, but you got to make sure they inhale or exhale fast. Or inhale slow, or inhale and keep it in there, right? Yeah, they can inhale fast, it's fine, as long as they keep it in there for how long? Yeah, more than 10 seconds, right? What else? They got to wash the mouth out, otherwise they develop thrush, right? So is that good for respiratory? What else other respiratory questions do you have?
In terms of the peak flow, usually we're not gonna ask it, because we were using it during the sim, and we had trouble calculating it, because it was like 400 milliliters or like 600.
No, what's 50% of it? No.
So you just give us a 50.
Yeah, if it's less than 50% or less than 70%. All right, so that's lung stuff, and we did neuro stuff, right? So that was a lot. Then they got some blood stuff. There's like 3 or 4 questions on blood, right? So you got to know compatibility, right? What's compatible with what? All right, so who's the universal recipient donor? So recipients AB positive. What blood can AB positive patients get? They could get AB positive, get everything. What AB negative? AB negative can get AB negative blood for sure. What other blood can they get? They get A blood, right? A positive blood or A negative blood? Can they get A negative blood? Doesn't A negative blood have B antibodies in it? So can they get it? Are you giving cells or plasma? You're giving cells to the patient. So you're just giving A negative cells, right? And you have to think of what is in the patient already. They have the only antibody they could have is anti-RH, right? They could have, that's the only thing that the AB negative patient has, anti-RH. If you have A negative cells to them, are they going to attack the A receptors? No. If they have A positive blood, they could have anti-RH, right? And they would attack it. So A negative blood is fine. B negative blood is fine. Can you give O negative blood? Yes, right? It's not the universal recipient, they're the half universal recipient, right? They receive everything but positive blood, right? So same thing that you think of like FFP, right? FFP, you are giving what? You're giving plasma, you're giving potential antibodies that could attack their cells, right? And then you have side effects, or not side effects, but blood transfusion reactions, right? What are your blood transfusion reactions? You have taco and trolley, right? And then you could have some immune responses from allergic. So you got allergic, febrile. You can have an infectious response. And then what's the one that's non-immune, but is not taco and trolley? Well, avian compatibility, I think of more as immune related. That's important, but also you can have too many PRBCs and too much iron, right? And how do you fix that? How do you de-iron somebody? To go to the dry cleaner, but what else would you do? Give them medication to de-iron them, deferoxamine, right? DFE them. Right. And then what else can you do? Or if you give to, how do you avoid tacos? Avoid Chipotle. What else? You can give diuretics such as Lasix, right, furosemide between units, right? Don't accept an order for 2 units. You give one at a time, unless they're like actively bleeding out. It's like, no, Professor Goldman told me only to give 1 unit, right?
That'd be a fun excuse to say.
So yeah, so as long as they're not actively bleeding, then you can give 1 unit at a time. When they are actively bleeding, which is more of the message 3, you talk about traumas. Yes, you throw all the units you can at them. They have a massive transfusion protocol. You're given all the units you can. After 4, you're going to check for what? You check the calcium, right? You check the H and H to make sure you don't have to give another 4, right? And you can check the potassium just in case some of the units were old. Okay, or you're giving them through a 24 gauge or something. All right, so that's blood. What else is there? So we get blood, and then yesterday. You want to talk about yesterday, or you good in yesterday?
Talk about Monday.
Talk about Monday. Well, I got up at 1 in the morning, and then so what else do you do? So you have to do renal and end of life, right? So with renal, we're not talking about acute kidney injury. You're only talking about chronic kidney disease. Just like with right heart failure, the most common cause of right heart failure is left heart failure. The most common cause of chronic kidney disease is acute kidney injury, right? So AKI, acute kidney injury, right? But you don't have to know that for this semester. That's message 3. We learn about AKI and pre-renal, post-renal, intrarenal, and BU and creatinine ratios, all kinds of fancy stuff, right? Nephrotoxins are still valid. Nephrotoxins can cause acute injury, right? And cause the creatinine to elevate, but you can have nephrotoxins as an outpatient, right? They could get 6 weeks of vancomycin and already have diabetes and hypertension damaging their kidneys, right? Why would you get 6 weeks of vancomycin? They have endocarditis or they have diabetes and osteomyelitis, right? That could be a reason why they're getting vancomycin, which is a nephrotoxin, right? Aminoglycosides are nephrotoxins. What else are in nephrotoxins? They have rheumatoid arthritis or osteoarthritis. They pop these like candy. NSAIDs, right? So NSAIDs, not Tylenol. Tylenol's fine. Take all the Tylenol you want, up to 4 grams per day. But other than that, that's not toxic to your stomach, and it's not toxic to your kidneys. But NSAIDs, anything else but that is toxic. Okay, so NSAIDs can do as nephrotoxin. What else causes CKD? Those of you guys online, are you okay? I'm just talking. I don't think I did a section on CKD, but I can draw things. People just answering the questions. Good. All right. So yeah, so I could be drawing pictures, but yeah, so you got causes, right? And then you have such as what again? So we have nephrotoxins and diabetes, hypertension are number 1, number 2, right? So they got pyelonephritis, a little section you gotta know about, right? We kind of talked about the UTI, how to teach, right? And do you want to go down the UTI pathway? It has two diversions. Then you go up to one ureter, the other ureter, right? You go up to the kidneys and you get hydronephrosis. Can happen from a stone, can happen, or you have a UTI that's ascended. It could descend from endocarditis, but that's a UTI symptoms. What are UTI symptoms? This FDUF, right? So fever, or not fever, but fever. You got flank pain, right? So costovertebral angle. You get CVA pain. All right, you got dysuria. What's dysuria? Painful urination. And what's the U? Is urgency, right? So they could have dribbling, or they have to go right now. Okay, and they got frequent urine. They frequently going. All right, so those are symptoms. The costovertebral angle really is cluing you in. That's going to make it all the way up to the kidneys. That's where your kidneys are, right? Also, it tell you have kidney damage as you look at the BU and creatinine. BU and creatinine are going up. That means your kidneys are probably involved, right? Especially if it's multiple pyelonephritis episodes like that cause damage over time. But also we can look to see if they have a UTI for diagnostic tests, which are, what would you look at? You may start typing these in there because that way you have a study guide. Gonna do 2 for 1. Okay. So we have general causes of renal, right? Which are what again? So general stuff causes we have our DM hypertension, right? What else? CHF can cause it. You got NSAID, you got nephrotoxins. Yeah, pyelonephritis can do it. We're doing a pylo section here. We're gonna pylo, we got causes. UTI, number one, it could be stones in the way, right? It could be tubes. You have a nephrostomy tube, right? Probably from a stone. That's how you fix a stone, right? You do nephrostomy, they just bypass the stone. The stone's blocking all the output. So we're just gonna put a tube above it to allow you to relieve the kidney from getting hydronephrosis, right? That's some of our complications. Get hydronephrosis and CKD, right? And then causes, and what's you got symptoms, right? That's FDUF, right? This is fever, leg pain, right? CVA. And then D was what? Is urea, which is what? Painful urination. And we got what's next? What's U, urgency, and frequency, right? So those are symptoms of a UTI. Of course, we're gonna have an SNS response if it gets up to the kidneys. That's a severe infection, right? And we've got diagnostic tests we can look at for, especially for UTIs. What's a UTI going to show on the diagnostic tests? Yeah, UA with Luke esterase, and or it's not, you're not going to both. It's because that's bacteria produce nitrites, right? That's their thing. Okay, that's what they do. They produce nitrites when they're in a space. Okay, so we can see if there's nitrite positive. And if you have one of those two positive, that means you have a UTI. Okay, rarely use hematuria, but hematuria is more of another cause of CKD, which is what? GN, glomerulonephritis, right?
Same thing with bands.
No, bands are on a blood test, a serum blood test.
It's more chronic. It's chronic.
Luke esterase just means there were white blood cells here. They left a slime trail. Okay, so what else? So glomerulonephritis can have what are we called? Science of diagnostic tests. We can have hematuria, right? It's kind of a symptom. You might have like RBCs on the UA. Okay, so they can have hematuria, right? And we talk about causes. We're really focusing on our post-streptococcal glomerulonephritis, PSGN. All right, recent strep infection, right? And where's the strep infection at? The throat or skin. Okay, skin is called what? No, MRSA Staph aureus, not strep pyogenes or anything. Strep agalactiae. What is it? Impetigo, right? So impetigo is skin strep. Okay. And that can then cause glomerulonephritis, right? All right, all the little our B cells release antibodies and they attacked the strep and now it's gone. But now all of a sudden, all the little antibodies that attach to those strep, it's like, well, they gotta go somewhere. So they don't exactly get recycled. They get into the bloodstream and they then clog up the kidneys, right? The causes, symptoms, diagnostic tests, and we got treatment, right? Treatment is kind of supportive. We can give steroids a little bit. There's all kinds of causes. There's many others, right, that you don't have to get into. We talk about nephrotic and nephritic syndrome and such. That's not something to differentiate. All right, but going back up to pylo, symptoms, complications, and then treatment / teaching, right? Treatment is going to be antibiotics. Right, you don't have to know which antibiotics at this point, but as far as interventions, right? Teaching, that's see above, right? You know, I think we mentioned all the little tips and tricks for UTIs, right? That's good on causes, I think. If you think of one more, we can add it there. All right, symptoms of CKD. What are your symptoms of CKD? You think of what the kidney does normally, right? So RBC wise, what does it do normally? It's gonna be low, right? You have a low H&H, right? And that's anemia, which is what symptoms? You have shortness, they got hypoxic. Right, hypoxia. It doesn't change. The cells don't care that there's a low O2 in the bloodstream, or the RBCs don't have O2 on their hemoglobin. Right, so they're hypoxic. They could be short of breath. They could be short of breath on exertion, dyspnea on exertion. Right, but they could get fatigue because they're not getting the O2 they want, and they're usually pale. Okay, they can have chest pain and MIs as a complication. but also they have clear lung sounds, right? That's kind of because hypoxia is hypoxia for PE, pneumothorax, et cetera. But how do you tell that it's anemia, right? They're like pale, right? Pale friends. And then also they have their lung sounds are fine, right? They don't have a big raging pneumonia. They don't have fluids up to their apices, right? They have fluid up to their apices. They have CHF, right? Usually until proven otherwise. All right, they got RBCs that are low. What else are functions of the kidney? So we got calcium phosphate issues, right? So low calcium. And what kinds of vitamin D? Due to low vitamin D, right? That's the job of, let's rearrange this actually. So the job of the kidneys is it's the last step before you before vitamin D it's the final stage of vitamin D, right? So you don't get vitamin D activity because the kidneys don't work. They don't do their blessing, right? It's a little baptism, right? To get them ready to go to do their job. What's vitamin D job? No GI absorption, right? Of calcium phosphate. So if you're not absorbing calcium phosphate, why isn't the phosphate also low? So calcium binds to phosphorus, so that means the calcium phosphorus should both go down. So why is the phosphorus high? Food can do it, but you're not all the calcium phosphorus you eat from your food is not going to be absorbed because you don't have vitamin D.
The concentration of it in the bones. It's osmosis, right?
So it's more with parathyroid hormone, but you'll talk more about parathyroid hormone later. But yeah, but you give phosphorus binders, right? As far as our treatment, right? So CKD, yes, you have all these symptoms, but usually the symptoms are going to bleed into all your complications, right? So you have low RBCs, we're going to be getting what? Anemia, right? And how do you fix anemia? You give iron, right? You give iron, you can give folate also. You're probably gonna hit them with some B12 just for funsies, right? But you give iron and folate, you give it IV or PO, right? What else can you give them? Give them the EPO because it's low, right? Low H&H due to, let's say, low EPO, it's better, right? So give iron, folate, EPO, and what else? Yeah, give them PRBCs. They're this low, right? So I'm going to give you this iron. Maybe in 2 to 3 weeks you'll get some more RBCs. But I'm bleeding, right? So no, just hang in there. Okay, do reassure them, just guided imagery. Okay, so what else? Low vitamin D. How do you fix that? You can give calcium, right? But cool. What else can you do? Give vitamin D. What else? What is it? Good. So we got to add on foods here. All right. So what vitamin D? So foods, right? So you recommend low phosphorus, such as, and high calcium, such as. Okay. But give calcium, vitamin D, and what else? Yeah, phosphate binders. Okay, so you have phosphate binders to bind the phosphate, right? So it's like a 1-2 punch. Like you eat the calcium and phosphorus, then and the vitamin, you get the vitamin D. Hey, we're going to the blood, right? Yeah, let's go. And then they just like kind of take them away. They say, "Where are you going?" It's like that looks splashy over there, right? So they trick them, right? So you're going to Chipotle? Yeah, I'm going to Chipotle. And you ditch your friend. You go to Taco Bell. I don't know. I'm thinking about Mexican food. Maybe it's taco. Okay. So yeah, phos binders, right? You can put your example names there. Okay. Vitamin D is vitamin D, but vitamin D is actually also called calcitrol. Okay. Calcium's calcium. All right. Phos binders or some phos binders. So Velamir is usually, it actually has some anti-ASCVD properties, which is nice. Right. There's aluminum works, anything that has a +2 charge, you can give. You give mag has a +2 charge, aluminum has a +2 charge, calcium has a +2 charge. So those work also. The Velamer is the big one. All right, so then foods for iron. It's tricky because they usually have high phosphorus. So usually you just got to choose the bottom row of that pyramid, right? Bottom row pyramid. Okay, low phos, high calcium, and then what else? What are other symptoms of CKD? They get hypertension. Why? They get fluid overload, right? Because they're not expelling it. They get hypertension, right? Fluid overload. This is preload, right? What else are they getting? They get RAS as well. So fluid overload, and we get oliguria, right? Because they're not peeing. I should probably put not peeing. Not peeing fluid. You get hypertension, you get excess fluid preload, fluid overload, right? Excess preload, and then the RAS gets stimulated. So you're not peeing fluid, you're not peeing, you have that's called oliguria. And if you're not peeing electrolytes, such as what? You get hyperkalemia, right? What else do you get? You get other stuff, you're getting BUN, right? Which is azotemia. What else gets elevated? Sodium, not so much, because sodium actually get diluted out because you're not peeing out fluid. So sodium is not part of the party. But you're gonna have low sodium, right? But what else are you not peeing out? Yeah, urea, so BUN. What up? Toxins such as meds could build up, good. But what else? Are you not peeing out naturally? Glucose, no.
They don't deal glucose normally.
What up? Hydrogen ions, good. You get hydrogen ions, right? It kill you, right? So U is for kidney failure, right? So it's metabolic acidosis, right? So hyper K, how do you fix that? Cocktail, right? How do you fix and then diet is what? Low, low K, such as not dead stuff, right? Not dead stuff, not K, not sodium replacement, sodium, what do they call them? Salt substitutes, right?
Yeah, no mustache.
No miss dash. And then so good. How do you fix urea? That's where you have to do dialysis, right? And we'll put C below because it's gonna get busy, right? So what else? Urea, there's no, I mean, diet wise, you can give them low protein, if not dialysis, right? And then hydro ions, right? Acidosis, how do you fix that? Dialysis can fix that actually also, but what else? You do bicarb. Or there's no like food recommendations that you would do. Okay. Yeah, you give it, they can be on like sodium bicarb tablets as an outpatient too. What else? So we finished here. So hypertension, how do you fix hypertension? Fluid overload. So you can do dialysis also. Not case bearing, right?
Yeah.
So you can do hypertension meds, or let's put it over here. So hypertension, you do hypertension, right? CHF, you do CHF. Diabetes, you do diabetes, right? You do all the things. ACVD, you fix that, right? So foods, low sodium, same thing for hypertension, right? If they are still peeing, you can give it, but usually up to a point is not going to be too pointless.
Just gonna be sending that third space after that.
It's just not going to work. It's like go to the skills lab, they'll be open, but it's not going to work, right? Skills labs GFR is 0. Okay. All right. So anything other symptoms? Kidney failure. So the symptoms kind of go with the complications. They can lead to complications. All right. So trying to think if we missed anything, but diagnostic tests, we can do an ultrasound, right? So usually they can look for pyelonephritis. You look for a swollen hydronephrotic kidney. You can look for other problems in the kidney. Usually CKD is shriveled, right? Small kidneys. right? You can look for the UA for pyelo, right? You can look, you're trying to look for the underlying cause, basically. You can do antibody testing for glomerulonephritis, right? Anti-ASO, is that the one? Anti-streptolysin. So you can do, say, glomerulonephritis. We can have, hypertension. We can look at what? Microalbumin, right? We got protein spilling. Right, that's the albumin creatinine ratio. Same diabetes, same, right? Also, you can look for as hypertension, plus you can also look at what to see if their diabetes is under control. Look at A1C under what? 7%, right? Other diet tests, you're just looking for the underlying cause and you're trying to get that fixed if you can, right? It's rare to have something genetic that caused it. Was it? BNP can look for, that could tell you fluid overload, but another thing is BUN creatinine, right? So BUN should, what's normal BUN? Yeah, 20-ish, right? And then creatinine is 1-ish, right? So 1-ish, and therefore the creatinine, which one's better? Better, right? Because that's a sign of muscle breakdown, right? You don't lose or muscle usage, right? So if you don't get it swollen overnight, right, with full of muscle mass, whereas BUN you can. BUN is from what? It's from protein breakdown, right? So overnight you can eat Thanksgiving, so you can have excess protein breakdown. Overnight you can be a vampire and go out and kill people and suck their blood, and you'll have hemoglobin excess, and you'll break that down. You'll have elevated BUN in the morning. Okay, but in the hospital we call that a GI bleed. Anyways. What else? So diagnostic tests, so your symptoms and your kind of complications wrapped up into one, right? We can talk about calcium phosphorus. We can, have complication of osteoporosis. Not peeing fluid, oliguria, they can have complication of, CHF, right? It's a big complication. And just cardiovascular disease is just an independent thing. Yes, it can cause CHF, but also you're not getting rid of lipids. So lipids are going to build up and you get ASCVD. And you have inflammatory things that you would pee out, but now you can't pee it out, and I have inflammation. And the inflammation is going to cause ASCVD, and ASCVD is going to cause hypertension. The hypertension can cause more kidney damage. It's all cyclic. All right, not peeing other stuff, right? So that can lead to your H's and T's, right? Lead to lethal rhythms, right? What are your lethal rhythms? VTAC, VFib, torsades, asystole PEA. So you want to be able to identify those, right? You want to know like your SVT, AFib, which one causes strokes? AFib does. Which one uses adenosine? SVT. What rhythm uses atropine? Bradycardias, right? So you want to know the kind of the treatment for these things. Okay. We're not getting into the weeds with all these little things from the previous topics. It's more big stuff. Yes. Yeah, we can do a breakdown. So a breakdown of which one's where. It'll be like it's almost like 60 questions are from the final, or from the last lectures, last five content areas. But again, the answer responses are from elsewhere, right? So you have like DKA as an option, right? You could have diabetes as an option. You have hypertension as an option, right? It's like hypertension. How do you bring down the blood pressure? Slow, right? Also, if they have TPA, you bring it down fast, so you can get that on board, right? How fast do you want to get TPA on board? Within 4.5 hours, right? So if they're a candidate for TPA, they should make sure they're not bleeding, right? Make sure your CT is negative. Make sure the blood pressure is good. There's the big things, right? So diagnosis says treatment, just see above, right? Non-pharm is just, avoid the stuff above, right? Do the CHF management, diabetes management, all the things we talked about before. So CKD I used to put with cardiac, but then there was two holidays, and then we had to work it around. And CKD is kind of the culmination of all the things we talked about before. So it should kind of slide into place, even though there's only 5 days to process it. It's still all of it should kind of make sense. All right. And surgery, you can do a transplant, right? And then RX for transplants is transplanted, and then what? It's anti-rejection meds, right? And it's the same meds you learned for myasthenia gravis and from MS, right? Cyclosporine and a few other guys, right? So anti-rejection meds, and for how long? For life, right? Complications, see above, right? Interventions, it's the same, or it's really like diet related. The right diet. Okay, so it's gonna be what kind of calcium, low or high? High calcium, if you can do it, if you can swing it, right? But high calcium, there's, I mean, like can be in dairy, but dairy is bad because dairy has high phosphorus, right? Dairy usually has vitamin D added to it, but it has vitamin D, but yeah. So usually we have medications to supplement it. Okay, is that it for renal? Anything else renal that you remember? All right, do you want to do end of life real quick? There's like 4-ish questions on end of life. What do you remember from end of life?
You know what, I did see something, when it came to the accesses, you said 3 months for the official to mature, but on the catheter, on the catheters, I'm sorry, my brain's getting there. You said 6 weeks, I just want to make sure, because I mean, this is your rules, not.
So for which one? Pick lines?
No,
Or
for the mature of the access,
maturing the access for a AV graft and AV fistula?
yeah,
So that's a good thing to put over here is under treatment. You can bring up a good thing is, I mean, it's not really pharmacological, but it's dialysis, right?
it is educational.
Right. So you have HD versus PD. You want to know the difference between the two, right? So you can talk about access. You could talk about the complications, a big one. That's a good one to ask a static question on, right? Like access complications or access sites, right? And this kind of brings in the first lecture, like, right, who should, because for good access, you could do surgical, right? Now, surgical, I'm talking like surgical. I mean, yes, one of the lines, a line placement is technically surgical, but we have lines you can place, right? Do you place lines for HD or PD? That's HD, right? HD lines. And we got PD catheter we can place, right? And they got to keep that thing clean. Otherwise, they get what complication? Not collapsy, but technically a cough. I don't know what it's called, but you have your output can be your effluent can be dirty, right? Dirty effluent. Anything that comes out of your body that's not pee or poop is called effluent and sputum, I guess.
I mean,
right?
it's kind of like the same. I mean, it's kind of the same thing. It just has its own name.
So it's something stuff comes out of your body, like impaired to dialysis. That's going to be a dirty dialysate. Yes. Straw. So it should be straw and clear is what, so you put normal, dirty, so normal. Right, normal is, or I can put it up here, PD catheter with normal, straw, clear output, right? Whereas PD, it's dirty, right? It can be all the things. It can be bloody, it can be poopy, it can be uriny, it can be bloody. I said bloody already, but it can be cloudy, it's infectious, right? So infection of site or insides, right? They got a perforated bowel, or they have infection, peritonitis, perf bowel peritonitis. Right, and then whereas HD has infection also, right? Infection where? Could be the access site, so it looks red and swollen, right? Like the AV graft, or it could be eclampsia, right? Because these are central lines, right? Our HD lines are which kind? We got a temporary one. Which one's temporary? Not the permacath, right?
It kind of is temporary.
You don't give a shit about.
I always laugh at the name. It's just funny to me.
Yes, permacath can be there for, it can be there for a while. They run out of sites. So why would they run out of sites? Because someone, right, gave or surgical, you could say here, right? You could have, you got to avoid PICC lines and midlines, right?
Yeah.
To preserve these sites. All right, so the surgical versions are AV, grafts and fistulas. Take time to mature. Right, so usually they'll have a permacath for X amount of time. Okay, yeah, so PD, you have an infection, which one has hypotension? PD or HD commonly. Right, so you got hypotension. Right, because you're taking fluid out. Right, or you give BP meds and then you do dialysis, taking fluid out, so it's a double whammy. Right, so like hypotension RX, right, you can give albumin a little bit. They usually do add a little albumin to pull fluid, but the albumin also can help with blood pressure a little bit, but we're going to avoid hypertensives. Right, usually wait till after, see if the blood pressure is good, then you can give their meds again. Okay, so that's a good point, dialysis. But end of life, dump your brain at end of life? What do you learn about end of life? The hospice versus palliative. Right, so pulse versus advanced directive. What else? PAS, right? Symptoms of dying. So our interventions. Right, so you can put for the dying patient, right? Dying patient. Post-mortem care. That's kind of the symptoms of dying, right? You have DABDA and you have skin changes and mortis, right? PAS, like what that involves, what pulse versus advanced directive, which one needs which one is MD order, which one has a POA attached to it, which one needs I don't know what else, which one needs a notary. Okay. Hospice or palliative, which one is, quality versus quantity. They both are, but which one is 6 months or more? Okay, more is palliative, less than 6 is hospice, right? All right, does that make sense? All right, so I can see what questions I had from before. If you want to do some questions, I'll see what I have from before. Exams. All right, so let's see, because before I think the renal was grouped with other things, subclavian lines. Yeah, this before was renal was grouped up above, but let's copy and paste these guys. So all patient leg problems, CKD. There's only a couple of questions. Let's copy it over into a new file over here. Yeah, I'll grab those also. So let's see, spring. All right, so let's make this bigger. Let's grab neuro and respiratory questions. There's a lot, look at that. Blood in their life. Just a whole bunch, cumulative, whoa. You got some nervous students that past semesters asking for questions. All right, so we'll know how many we get through. Maybe we'll wrap it up at 7. All right, so what about low EPO? What are they at risk for? Anemia, right? So hypercalcemia, why not? Why is that wrong? So you're always going to put the rationale here. They have low calcium, right? Because next time we get asked, the question could say they have low vitamin D. What would they suffer from? And so the right answer would now be low calcium, right? Anemia is due to low platelets. So low platelets, low EPO. I had to pee on the mind. All right, so we got peeing and drinking it today. That's cool. All right, so then you got blood clots. All right, so is that a thing? No. And what a hyperkalemia. That's a complication of CKD, but not due to low EPO, not due to low EPO. Okay, and it's the same question. It just offers, do you know your labs, right? So calcium should be, it's hypercalcemia, right? This is hypercalcemia, right? This is what? Anemia, right? Hemoglobin less than what? Usually I think 12-ish is defined as anemia. Okay, D-dimer, that's looking at VTE stuff, right? Not related, but can tell you if you have a what? Clot, right? And KF 5.9, this is hyperkalemia, but not due to low EPO. I do have another question. Look at that. This is just the same question, but now it's asking that this is hypercalcemia, right? Right? Due to causing a stone. Leading to pyelo. Right, the costovertebral ankle pain and urinary sediment is a sign of a stone. Shortness of breath on exertion, pallor, clear lungs. This is anemia, right? The right answer. FYI. All right. So then swollen lower extremities with pain and erythema, that's a sign of this is a DVT, right? Not related, as mentioned above. And then wide and QRS complex, right? What is that? That's hyper K, right? Yes, it can have also what, right? This is hyper K EKG changes, which also includes, because it could also be an EKG that looks hyper K like, which has what? Peak T waves, right? Peaked T waves. Okay. And bradycardia and lethal rhythms. Okay, it's usually PEA. All right, I'm tired of this. Okay, let's go on. So we got nurse would expect lung function studies for what? So severe asthma. This is not terribly accurate. Let's change this to 60. So this is a sign of asthma with less than what? 80%. Okay. Sputum is that yellow. This is pneumonia, right? Not a lung function study. Right. Increased residual volume. We didn't talk about residual volume, so we could put, let's just change that to vital capacity. Vital capacity is not usually elevated, right? Because yes, a COPD patient has air trapping, but that air is trapped and not useful. They actually have a decreased vital capacity. But yeah, this is vital capacity. This is vital capacity not usually elevated. When low, it is what? Due to neuromuscular problems, right? Such as, because all talking about peak lung function studies, right? So there's overlap and bleeding into neuro with our neuromuscular problems, right? The Guillain-Barre specifically, because going to that nerve, going to that muscle, right? And that muscle's not able to work good. That muscle could be a what? A diaphragm, right? So Myasthenia Gravis and Guillain-Barre, we're looking at vital capacities a lot, such as Guillain-Barre and Myasthenia Gravis. Danger when less than 1 liter, right? Increased forced vital capacity. Asthma has decreased FVC, right? This is measured with a what? How do you measure forced vital capacity in asthmatic every day? Measured with a PFM, right? To do an FEV1, you need to have a fancy setup computer that can hook up to and assess with a little graph and such. Okay. Chronic bronchitis, patient says what is correct about the disease? What tells you they know their disease process? That the nurse explained the pathophys and they understand it correctly. A, got this because I lack a protein called alpha antitrypsin. This is emphysema, not chronic bronchitis. I have a lot of feet swelling because of the disease. This is cor pulmonale due to chronic hypoxia due to chronic bronchitis, right? The correct answer. All right, I got this because I live in West Virginia. This is emphysema. All right, pollution. Yes.
I was like, is there a joke with that one?
No, they're coal miners. That's what they do.
So- I thought it was just a joke, honestly, I'm not gonna lie.
All right, so no, just kidding. So this is where coal miners live.
I mean, you could say borax.
Borax a little bit, that's the Midwest a little bit.
If I
Utah.
would've- I would've-
What do they call it? This is the essence, wetness is the essence of what, anyways. So we got to, I want to get those chubby fingers like my wife. So this could be a SATA. It could be like a SATA, right? Let's add another one, E. So give me another thing they might state incorrectly or correctly. Right, also the death. That's also true, but that's kind of non-specific. I will suffocate you a popped lung. Right, so that's what this is. Spontaneous pneumothorax, right, due to emphysema. So the correct answers would be this one. So the test could ask you emphysema, and then you just pick the other answers, right? Or the test could ask chronic bronchitis, and do you know, can you differentiate between chronic bronchitis and emphysema? The treatments or the complications or the like, do I teach pursed lip breathing? No, right? So I could say I will, right? Let's put an F right here, right? So I will need to after kissing my wife and exhale slowly, right? This is pursed lip breathing, which is what? Emphysema patients, emphysema. Okay, so nurse knows which of the following labs are consistent with a COPD with advanced disease. So I didn't tell you a correct eosinophil, but I probably skipped this one. I wouldn't give you this, but they don't have renal failure. This is not related. Right. PO2 of 81, you have to know that. What is that good or bad? Is that related? Right, this is normal. What about 18.9? Let's make it 19.9, make it obvious. Okay, this is high, which is of polycythemia, right? A complication of chronic bronchitis. Is it differentiating the question? So we assume it's either one, right? So this would be the correct answer. All right, acute COPD complication. Dry cough, non. Just looking at acute, right? So this is a complication, right? But is a chronic complication, right? From cor pulmonale. I didn't really differentiate acute versus chronic, but I'd probably say it's COPD complication of chronic bronchitis or COPD complication of emphysema, right? But we have to think of the worst case scenario. What's the worst case scenario? You got accessory muscle use, lethargy. That's a problem, right? It's like this is a hiring, right? COPD patient from COPD acute exacerbation, right? I'll probably give you some more data saying they have their symptoms are worse and they have that's accessory muscle use lethargy, or they are brought in and they have dry non-productive sputum, right? That's just pneumonia. All right, poor appetite while on BiPAP mask, deal with it. All right, it's not an acute complication. Yes, COPD exacerbation can lead to that, right? It can be on BiPAP for a while. All right, nurse is caring for a patient with acute asthma exacerbation. What would they receive? Levobuterol is a good one, right? That's a SABA, right? This tiotropium is a LAMA, right? And fluticasone is a ICS, right? Salmeterol is a LABA, right? So which one's the right one? The one that's short acting for acute problems, right? So you can also say this is a SABA. We can also put down other fast acting or other short acting, right? Or you could say other things we could do for asthma exacerbation include what? You could do a SAMA, right? Such as ipratropium, right? And what else do you give? You give magnesium and IV steroids, right? Or I can put that down here. ICS is for controlling or preventing. I don't even know which one it is. I don't know. For controlling, let's just say, right? So for controlling, it's more for preventing, but I don't like those adjectives. All right, but anyways, it's for controlling / preventing. There we go. Problem solved. All right, preventing asthma exacerbation. Right? IV steroids are for asthma exacerbation. Okay. All right. So this is a LABA. A LAMA would be, or SAMA would be this. Right. What findings does the nurse expect with an emphysema patient? So this is a sign of what? Wheeze, cough from sputum, chest tightness. This could be asthma. If it is a lot of sputum and a lot of coughing, this is chronic bronchitis, right? So the question is asking about emphysemas. That's not even on our radar. My girlfriend says my lips are always salty when she kisses me. I have had this disease since I graduated med school.
That'd be the best.
Unless it's Doogie Howser, right? It's usually asthma happens in childhood, whereas and this would be alpha-1 antitrypsin deficiency, alpha-1 antitrypsin, AT, right? Is it causes emphysema. So yeah, I guess that could say it. So, but that's kind of, I'd probably give you more clear things if they happened as a young adult, right? As a young adult, not due to smoking. Okay, asthmatics usually present younger than that, right? There is adult onset asthma, but we didn't talk about that. All right, I'm often overweight and retain a lot of fluid. What is that? Is chronic bronchitis causing cor pulmonale, right? And then the patient has an MCA stroke. What are you going to expect? Cortical blindness is PCA, feeding occipital lobe. And you can put the other PCA findings because it could easily interchange those, right? Upper extremity hemiplegia. Yes, if contralateral, right? Didn't really specify, but irregular breathing patterns. This is medullary involved, pontine strokes due to basilar arteries, right? Hemorrhage. Doesn't matter how it happened, it's just stinging blood supply. Incontinence. This is ACA, which includes, right? Nurse interventions you would do for basilar artery stroke. Speech therapy, you could, right? This is the ocular bulbar. Checks out, right? Behavioral therapy. This is ACA, right? It could be PCA if it's affecting a deep nuclei. You could argue that. From PCA, right? But we're talking about basilar artery affecting the brainstem, right? And the cerebellum. Visual scanning. This is PCA and MCA, whoops. Due to HH, right? Not H/H, but HH, right? And then balance training. Who's that? This is Sarah Beller. Issues, Sarah Michelle Gellar. Issues due to PCA stroke, right? So which one's the right answer? Speech therapy, right? Speech therapy you'd also do for basilar artery. Hold on, let's add this ocular bulbar checks out, but right? MCA strokes affect temporal lobe, right? Temporal lobe homunculus, which is where we have voluntary control, right? Of swallowing and speaking, right? So yes, it's ocular bulbar. So yeah, that could be basilar artery, but it also could be MCA is right going to, you know, your FAST assessment, right? Has what? Face, right? Arms, and so it's the face part. And speech. Well, yes, speech is part of face also. So it's... Yes, basilar artery is BFAST because it's basilar artery. They was FAST assessment for like 20 years, and then the basilar artery is like, what about me? What's right? So then they added the B and the E to it. So you got balance and eyes. So the B and the E is your basilar artery attack, and PCA as well for the eyes. What's up? Balance training is not going to be cerebellar. I mean, you could say it's face and arms, right? Unless they walk with their arms, they're like a double amputee from, you know, seen the guy that has like two arms and one leg. So yeah, if his arms are, he's going to have some gait apraxia, or ataxia. All right, what else? We got patient presents to the hospital with left-sided hemiplegia, dysarthria, and headache. So what does that tell you? You got dysarthria and hemiplegia, half his body doesn't work, and he can't speak good. Well, is it the upper half or bottom half? And a CT scan shows areas of white to the right hemisphere. That's not good. That's a bleed, right? Vital signs are 205. That's too high for bleed, right? For ischemic, it's perfect, right? We'll continue to monitor. Heart rate 46. What should you do? Bring it down because it's a hemorrhage. You got to bring it down pretty quick, right? We're not doing TPA there. This is for TPA, right? TPA, which is not for white on CT scan bleed, right? And what else? And you do bring it down fast if TPA indicated. And you can go to town with the rationale, put all this extra stuff on there, right? And we got to bring the SPP below 140 the next few hours. That sounds good. All right. What about do not treat until over 220? This is for ischemic stroke, right? So this could easily say they have gray on their CT scan. You have all these symptoms and your blood pressure is 202. So now the right answer would be ischemic, that option C, right? And bring the SPP below 160 over the next 24 hours. That's too long. This is for vanilla hypertension. Okay. And once you're supposed to bring it down by 25%, you have skills lab PTSD. 25% of 206 is what? Well, 10% is 26, right? And 26 and 26 is 52, and half of that is 13. So that's what, 65 points. You should bring it down in 24 hours, right? Which is, 150 tops. Anyways, that's what you have to do. You have to know that in real life, but not for the test. Priority nursing diagnoses for PCA stroke. They have breathing pattern issues. This is basilar artery stroke. Risk for disuse syndrome. What the heck is that? Immobility, right? Is immobility a problem with PCA strokes? Is there something better, right? So not really, right? Because you might have eye problems. You might have some, what else with PCA? You might have some hallucinations. You might have hemiplegia, so that could be causing immobility. But is there something better? Impaired verbal communication? No. This is what? This is MCA primarily. Could be ocular basilar with dysarthria from oculobulbar, right? What else? You got a class? All right, we'll switch out.
All right, come on out.
All right. Thank you, guys.
Thank you, Robin.